Hi, everyone, and welcome to today's Facebook Live Ask the Expert series. My name is Alana Feuchter, and I am the Patient Insights and Advocacy Advisor for NOCC. As many of you know, we started this program last April as we were in the early stages of COVID. We thought that given that we are in a new year and there's been a lot of updates, it made sense to bring this subject back. We will have an opportunity at the end for questions. So as we go through this, please feel free to type your questions in the chat box. But do keep in mind that our experts today are going to educate you so that you know what questions to ask of your own physician. They will not be answering anything about your specific case. So now I am delighted to introduce our two speakers for today. We have Dr. Stephanie Archer, who attended Jefferson Medical College and completed her residency at UPMC Shadyside. After that, she joined her current practice in 1999 and is now the lead physician of UPMC Superior Family Medicine. Dr. Archer is also a two-time survivor of ovarian cancer herself. So she brings the experience of a physician and a survivor to us today. Like many women, she was diagnosed in a later stage and was treated for a recurrence in 2019. She is now med, yay, and enjoys working with the NOCC Pittsburgh chapter to help spread awareness, mentor newly diagnosed women, and captain Archer's Army for the Together in TL walks. Our other speaker of today is Libby Earnhardt, who got her BS at the University of New Hampshire and then spent time in East Africa with the US Peace Corps before getting her Master of Science in Physician Assistant Studies at Chatham University in Pittsburgh. She has practiced infectious disease medicine for over 20 years and serves as an adjunct faculty at Chatham. She chases around her family, 3 boys and 2 dogs, and enjoys swimming with her master's swimming team in her spare time. But she admits, due to the pandemic, that has not happened as often as she would like. So now I would like to welcome both Libby and Stephanie, and I'm going to start in with some questions. So welcome, ladies. Thank you so much for giving us your time today.
Thank you.
Thanks for doing this.
Great. Libby, the first question is for you. It has been, as I said, almost a year since we've had a lot of COVID, or COVID has entered the United States. Can you just sum up, we're going to start with the basics. What happened in 2020 and where we are now?
I think from an infectious disease standpoint, it's just an amazing question. You know, a year ago, I was sitting in the same room and I had heard about this virus that was in China. When you look back in December of 2019, there were the first reports of the disease, though they look back and they think it was probably earlier than that. By January 12th of 2020, they had sequenced the new SARS-V2 coronavirus. And the first cases in the US were at the end of January. The first cases that we tested in Pittsburgh, which is where we both practice, locally we were able to do our own test in our own hospital by the end of March when we were having our very first patient. Up to that point, we had to argue and plead with the state to be able to even test a patient. When you look back on the early cases in March, we had all of these rules. Don't give them steroids because of research out of China. Use hydroxychloroquine. Intubate them early. Don't use high flow. Get them plasma and get these plasma banks up as soon as we can. And now here we are 10 months later saying, avoid the ventilation as much as you can. Steroids are one of the only things that we know makes a big difference. We have access to remdesivir, tocilizumab. We are using these antibody-based therapies. And as we are hitting our highest local numbers in December, we were vaccinating our first healthcare workers for a disease we didn't know about a year before. And to me, that's amazing. It's absolutely amazing. It's sad, horrible, and just amazingly, it speaks of opportunity and optimism. I want to make sure that you guys know that we're just looking to help you with your questions. We don't necessarily have the answers. We have a lot of information, but there's so much change. This morning, 3 more things came out. And it's just constantly changing, and knowing what to look for and knowing what good questions to take to your clinicians is really important. It's also good just to point out, we both practice in a corner of Pennsylvania where there has been there's been a lot of research in this part of the country, in this part of the state. When you look at treatments that have rolled out across the country, you'll hear differences. And a lot of that depends on where the research was coming from. If there were big systems in the hospital that had big pharmacy teams that could help sort through all of the data. And so when you hear things, if it doesn't ring true with what you experienced or what you heard, that often is the reason. We were very fortunate to be able to have their access to a big system with a lot of research. So that's where we are. It's been a crazy year.
It's been a ride for sure for all of us, right? I'm sure for you especially. The next question for you, Steph, can you tell us a little bit about the symptoms of COVID?
So that's another crazy thing, right? Because the symptoms have been so different. You'll hear about someone, I tested positive, I was fine, it was nothing. And then you'll hear that, both of their parents, passed away or were really sick with COVID. So they do vary. They vary in the types of symptoms, they vary in the duration of symptoms, and even the severity of symptoms. There are some classic ones, which everyone probably has heard of by now, right? So fever, flu-like symptoms, achiness, headache, just being really tired, loss of taste or smell. Sometimes that's all people have. And that is usually going to be a positive test if somebody has that. There's some GI symptoms. It's usually more diarrhea, less so nausea or vomiting, sometimes a sore throat. And then sometimes the complications that come with COVID are the chest pain and the shortness of breath. So most people will get better after 3 weeks. Some people it's 3 days, some people it lingers. And unfortunately, about 10% of the people have symptoms that last longer than a couple of months. Those are the long haulers that you hear about. Most people do get better, but the reason why we try and keep the disease in check and talk about wearing masks and being careful is because the more people get it, even if it's only 10% of the people that are getting sick, more people means that 10% is a higher number. So those are the symptoms. They do mimic the flu. So we're going to talk about testing and how you know the difference. You've been exposed to somebody and you're experiencing those things, you should consider yourself positive until you know otherwise, and then maybe even still consider yourself positive, depending if who you've been around.
You lead me into my next question, which is, can you explain a little bit about the tests that help diagnose a COVID or a COVID diagnosis?
So I'll take that one. The two main tests that are going to be out there that are genetic, you'll hear some, I'm throwing the words because they're actually on the CDC's website. They use the word nucleic amplification or /NAT, N-A-A-T, which is just an abbreviation. Or you'll see PCR. And basically these are the tests where they're taking a saliva or a nasal swab, or some of the patients refer to it as a deep brain biopsy, which it is not. And they're looking for and amplifying a teeny piece of RNA that's specific only to the SARS-CoV virus. So that is the the PCR or the NAT test. They're really sensitive, meaning they are specific, they're sensitive, and they find just the littlest amount. These tests are also very specific, meaning they don't have a lot of false positives in them, which is great because you want to, when you're diagnosing someone who's critically ill, want to have confidence in the diagnosis you're making. So in most of the hospital systems, you'll see this. You will also hear of antigen testing being done. And antigen testing is some of the quicker and rapid tests that you're hearing about. it is also looking for something specific to this virus, but it's looking for a specific protein. So unlike looking for a string of the genetic code of the protein, it's looking for, or a genetic code of the virus, it's looking for a specific protein. They're less expensive, they're cheaper tests, they're often saliva. Some of these are the ones that you're seeing that are the mail-ins. It is less sensitive. So it will miss more COVID. However, it is still very specific. We don't see it cross-reacting with other things as well. So those are the tests that are used to diagnose COVID. The rapid tests or the antigen tests, and then the genetic tests, which are the amplification / PCR tests. You will hear...
Go ahead.
I was going to say, you'll hear about the antibody tests. And those are different. The antibody tests the antibodies are what our bodies make in response to infection. So they're the things that then our immune systems use to protect us. These are the tests you hear people talking about. I donated blood. They said they'd check for COVID antibodies for me. You hear a lot about these tests. These are not tests for diagnosis because we don't know what to do with them. They are a blood test, whereas the other tests are tests of saliva or snot of some sort, as my team sometimes says. And they're hard to interpret, which is why we don't necessarily use them to diagnose. We don't know how much immunity do they mean. Do they mean you're going to have immunity? We have a lot of positive patients via PCR who were sick and had COVID, and then they don't have antibodies. So it's interesting information to have, but it's also confusing and leaves us a lot of question marks.
Of course, I think that's been the theme of this since the beginning, right? A lot of questions, and we keep learning as we go. Mm-hmm. When would be the best time to test if you think you have been exposed or if you're seeing symptoms?
So the best time to be tested is always when you're having symptoms. So somebody who is having fevers, cough, lost their sense of taste, usually the viral load that's going to be detectable or the antigen tests that are looking for proteins associated with the virus will be at that point. But if the patient has been exposed, and let's say, 3 days ago, I was hanging out with someone who came up as positive, and I go to get a test done, and I'm not symptomatic. A negative test does not mean that I might not have a positive test in 2 days, right? So the reason we say the best time to get tested is when you're symptomatic is because there should be evidence of that virus in you. And we do have things that aren't positive when they should be. But in the world out there, when everyone's talking about I got exposed and I had a negative test, I can go about my business now. We have lots and lots of cases where I was exposed 4 days ago and I went and got tested and it was negative. And that's great news. But all that means is that day, there was not there was no reproducible evidence of that virus. But 2 days from now, I could get a sore throat or have a cough or a cold or lose my sense of taste and be swabbed and be positive. So we have to always acknowledge that that test is just a time lapse of that moment.
So if someone had been exposed, how long should they, maintain distance from other people, quarantine at home?
So the recommendation is 10 days from, if it's confusing also, but if the last time that you were exposed to someone and you were in their window of contagion, so someone says to you, you were exposed to Stephanie 3 days ago, she became positive or sick within a couple days of seeing you, then I need to stay away. I need to quarantine for 10 days from that contact, from the last time I was with her. If she and I are in the same house, then I need to extend it to 10 days, at least 10 to 14 days from when she goes back, if that makes sense. Assuming that at any time, and Stephanie can come in on this, at any time she could, in her illness early on, she's more likely to infect me, but at any time she could infect me. So my day one of my isolation, if I live with her, has to start when she basically goes back to work and she's cleared. which is hard for families and is very confusing.
It's very hard, especially for people who have, you've got kids or you're the primary caretaker for somebody. But if, your child tests positive on day one, they are probably contagious to you when they, you wipe their nose or, clean up after them. They're contagious through days 1 through 10 for the most part. And I can touch on that later, but for the most part, after 10 days, if someone is feeling better, they are not contagious. However, day 9, the mom could have gotten it. So mom needs to stay home. That when Libby's saying start from the day that they're free, that's what she means. So at the end of the sick person's isolation, because technically we have sick people isolate, people that have been exposed quarantine. So at the end of someone's isolation, if it's a household member or someone that you've been very close with during their time, you need to then quarantine. So it's frustrating. It's confusing. The CDC does have some nice algorithms and calendars, that people can look at, or you can call your doctor because we're getting really good at answering those questions.
Mm-hmm.
When would you suggest, staff, that someone should seek medical attention if they test positive?
So if you test positive, I would say touch base with your doctor, your PCP, or if you're a current patient in treatment, I would definitely touch base with your oncologist. I would let them know so that it's on your history. Should you develop problems later on, we know about it. Should you have any questions about isolation or quarantine and so forth, they can tell you. Our office, when we get a positive test back or when we hear of a patient being positive, we have them do a check-in with us every 48 hours because sometimes the symptoms do worsen. Mm-hmm. It's also probably a good idea to call your doctor so that they can tell you how to treat it. There are lots of things that you can see. I saw a couple of TikTok videos going around about this cocktail that you're supposed to take. And some of those things that were mentioned in there may not be good for someone with high blood pressure or someone who's already on blood thinners. So your doctor is going to know what's right for you, what you should take, what you shouldn't take. I do tell people to consider having a COVID kit already at home, because when you're already sick, who wants to go and buy the Tylenol and buy the cough medicine? We should have thermometers at home. And one of the things I encourage people to think about is a pulse ox at home. In the beginning, those were really hard to come by. Our hospital gives them to ER patients after they leave and when they leave the hospital from being admitted. But they're more readily available now. And checking your oxygen level, that's what a pulse ox does, is it checks your blood oxygen level. It also tells you your pulse.
Yes.
And if you are having a pulse ox that's less than 92%, if you're having a heart rate that's persistently elevated, obviously if you're having chest pain or shortness of breath, those are reasons you should definitely be seen in person for an evaluation. We're getting really good, like we're doing now, of doing telemed. We can see our patients over the internet and we can talk to them. But if they're having those types of symptoms, we make arrangements for them to be seen, either at an urgent care that can handle a positive patient or in the emergency room. But you should always call your doctor's office first. If you think you have COVID, I'm going to put this out there because I deal with it at least a couple of times a week. If you think you have COVID, please do not come into the doctor's office. Especially if you're in active treatment and you're due for treatment or you're due to see your oncologist. Obviously, the people that are in that waiting room are even sicker than the patients in my waiting room. So call the office first before you go in.
Mm-hmm. Good questions. By now, we are all aware that wearing a mask, social distancing, washing your hands helps decrease infection. Is there anything else that we should be doing to reduce risk?
First of all, I would still say wear a mask, wash your hands, stay home when you're sick, and avoiding crowds. I mean, washing your hands and doing those things, wearing the mask and staying home, are really very important things and things that we know can really make a difference. Libby talks about she's been around COVID patients since day one, and she wears her masks and does all those things. And luckily, she's been fine. So it does work. She's been right up there next to those patients. We do know that people with low vitamin D levels might do a little bit worse. So if it doesn't hurt, especially here in Pennsylvania, we don't see the sun right now. Everyone's vitamin D levels are a little low. So taking vitamin D supplements may help. Taking care of yourself, just like you do when you're going through treatment and chemotherapy. You want to try and eat right. You want to sleep. You want to get your exercise. You want to do all the things that keep you in the best shape that you can, so that if you get sick, your body can fight it off easier. And you also want to be taking care of your chronic diseases. People with diabetes, hypertension, obesity, they all do worse when they get this disease. Yep. And I want to remind people too that we should be continuing our routine medical care. We should be doing our screenings. Everyone wanted to avoid the doctor, and quite truthfully, we shut down for a little while too when we first did this in March. But it gets to a point, it's been a year. So you do need to see your doctor. You need to get your blood work done for your thyroid disease or your diabetes. Masks are a hot topic lately. We were talking about this before we came on, that they're talking about double masking, right? So the very first thing is wear a mask. If you're not wearing a single layer mask, chances are you're not going to be wearing a double layer mask. And if you find the single layer mask one mask uncomfortable, you're probably not going to wear two. So at the very least, wear a mask. Now, a mask should be, if it's cloth, it really should be at least 2 layers. The gaiters that people wear up over them, their faces probably don't work if they're just thin layered. If you can tolerate a mask and wear 2, yeah, that probably helps, because we know it's spread by droplets. Anything that's going to act as a barrier is going to help. If you need to wear 2 masks, one for your nose and one for your mouth, go right ahead, just because both of those things should be covered at all times when you have the mask on. And the other thing that the masks do is they keep your hands, when you touch something, you touch your face, you introduce that like right underneath your nose, whatever droplets from the person that coughed or sneezed before. Mm-hmm. So if you have a mask on that you're constantly needing to adjust, you're defeating the whole purpose of it. What do you think, Libby?
No, I think that's good. There were a couple calls, just system calls from an infection prevention standpoint about Dr. Fauci making comments about, well, I think double masking isn't going to hurt. And our comments were, it'd be awesome if we could get single masking to go well universally. We know this is droplet, and droplets are just things on bits of moisture that come out of our nose and when we cough. And so we do think that anything that catches those droplets is great. And so they come out of our nose and they come out of our mouth. I think his comments in the last 2 days were more in reference to if we have other variants, which we can talk about. If there's more contagion, could 2 masks be better? And I'm sure his answer is, of course that might be better, but I don't think that the goal should be for universal double masking. I think it would be great if we could get single masking and really cover the nose and the mouth would be a fantastic place to start.
Yes. Studies are showing that the infection rates are highest, as we've talked about, in confined indoor spaces. So in those places where people can get outside and it's not 20 degrees, or even if they like to be outside in 20 degrees weather, can people, especially survivors, take walks outside with friends? Because we're all missing that human contact too.
Yeah, we all are. I think that remember that when you're in treatment versus when you're in maintenance versus what your treatment regimen is going to play a huge role, which is where you really are always talking with your oncologist and just figuring out who you are in that immunosuppressed world, right? Where you fall in on that curve, because that word gets thrown around a lot, but there are differing degrees of it. And your oncologist is the perfect person to help. But I think that the answer for COVID is outside walking with space is fantastic. I think that I actually volunteered to vaccinate with a couple of friends. We are all now vaccinated for COVID. We all went in the same car because it was a ways away, and we all wore masks in the car because there's a degree that we we don't know about. So I think that carpooling with unvaccinated people to the walking place might not be the thing to do, but certainly meeting and going outside where we know we've got a lot of fresh air. We know that the outdoor air makes a big difference. I think that that's something that you need to be able to consider doing. If you can't get 6 feet or space from someone, then certainly put a mask on. And of course, for those who are in active treatment, the same protections apply as they always did. You know, the recommendations that your oncologist gives to you because you're in the throes of chemotherapy infusions and your counts are dropping still pertain. They don't change.
I want to go back to something we talked about before about that this is droplet based and it's not as much touch based. Of course, I just touched my face.
It's so hard not to.
Should people who are immunocompromised, in the beginning, you know, people were wiping down packages and groceries. Is that something that you should be thinking about?
I think the answer is the primary risk for all of humanity is the herd. And I say the herd because in infectious diseases, we refer to us, the people, as the herd. So it's being close to someone who is coughing in the air where you are. So we went through this beginning where everyone was leaving their groceries outside and wiping down the bags with, you know, bleach because they were worried that they were going to bring them into the house and then touch them and then infect someone. And that is just not the way that this respiratory virus, much like most of the other respiratory viruses that we deal with, including the other coronaviruses, are transmitted. That said, somebody who's in chemotherapy, and honestly, any human being, when they take their box out from their cupboard to prepare the food, and it's the cardboard, and they open the plastic and they pour it in, before they eat that food, washing their hands is always a good idea. You know, washing your hands after preparing the chicken is always a good idea because of the salmonella, not because of the packaging. So I think that we need to be more mindful of the things we always should have been doing, which is washing our hands before we eat and washing our hands when we touch our face. But I don't know that we need to buy out all the bleach wipes again to wash down all the plastic and cardboard that houses our food. Is that a good answer?
I would say
makes sense. Yeah.
I would say those surfaces that everybody touches should be wiped down, right? And those are the surfaces that you should really be careful about, you know.
Right.
The elevator in the hospital where everybody has been touching the button and possibly wiping their nose and touching the button, and then you come along 2 minutes later and touch the button,
right?
And touch your face. You know, that's the those are the surfaces that we should probably be worrying about.
Right, the high touch surfaces, absolutely, and we're washing those down more often than we ever did before. Because of that. The doorknobs in the schools, in the classrooms, you know, those high touch things. Absolutely.
I know we had some other questions, but I want to make sure we get to some of the really pressing ones right now. So okay. I want to jump right in, of course, and ask if you can talk about how the currently approved vaccines work, how safe they are, and do we think they're going to need to be given annually like the flu? Throw that to you first.
So vaccines in general, they work because they give us either a sample of a weakened virus or a piece of a virus, and then our body recognizes that and makes immunity to it. So what's different about these vaccines is they are called mRNA vaccines. RNA is something that is in our bodies, in our cells, and it does just what that M stands for. It's a messenger. So it tells cells how to make things. So the two vaccines that are available right now, they're very similar in that it's a piece of mRNA that is coated in a substance to help protect it from the normal enzymes that are in our body. It gets into the cells and it tells those cells to make the protein, a spike protein, that's similar to the protein that Libby was talking about when we do the tests. We're testing, it tells your body to make this spike protein. So the cells make it, the RNA then gets dissolved, it goes away, And the protein then attaches to the cells and the white blood cells in your immune system, and it recognizes it doesn't belong, and it starts to make antibodies for it. So what's different about this vaccine is it's not giving you any type of virus. So you cannot get sick. You won't have a positive test because you got the vaccine. The mRNA, it dissolves. It never enters any nucleus of a cell. So it does not change your DNA, which I know has been a question that people have, but it doesn't interact with your own body's DNA. Is it safe? They seem to be. I mean, there really seem to be the adverse reactions. They are out there. We hear about them on the news, but we've now given millions. I think we're up to maybe 26 million vaccines, but the reaction rate seemed to be pretty low, 4 to 11, based on whichever per million, depending on which vaccine. Will it? Will you need to get it again? We don't know. I mean, that's the best answer that I have. I mean, viruses do change. We have to get the flu shot each year. We only get shingles shots once, which is, you know, a virus. So this virus does seem to be changing. We may need to. It also just hasn't been that long that everyone has been vaccinated so that we can really see how it responds to it. So I wish I had a better answer for that. So anytime you get the vaccine, or when it's your turn to get the vaccine, you should probably talk to your doctor, take a look at what your own risk of having a reaction is. If you're someone that's had anaphylaxis to a previous vaccine and needed to get an EpiPen or needed to be treated in an emergency room, you are at higher risk of having a reaction to this one. Doesn't mean that you will, you just are at higher risk of it. So you should always be in a place that's prepared to handle a reaction, again, if you have it.
Do you know if people with cancer were included in the clinical trials for either of the vaccines?
They did not include people that were on immunosuppressive drugs or cytotoxic drugs in these trials. And part of the reason is because those people can have reactions just to the medicines that they're taking for their cancer. So when they look at what type of reactions people are having to the vaccine, it's a little bit difficult for those people. It doesn't mean that you can't get the vaccine. In fact, you're immunocompromised if you're in treatment, and you are probably at increased risk of complications for COVID. So you should, again, talk to your oncologist. It does seem to be safe. It may not be as effective because you are immunocompromised. So the current vaccines, the thing I forgot to mention is they are about 95% effective at preventing severe COVID. So that number might go down a little bit, but you will probably get some response and some benefit from taking it. Anything, Lib?
No, I was going to say you'll hear a little bit, and there was just a report today about some of the different variants and what these new strains that they're seeing of this SARS-CoV-2, what that means. There's 3 you hear about. There's a B1351 in South Africa. There's another strain, B117 in the UK, which is made a lot of news because they have a lot of illness right now. And then there's a strain in Brazil, and you'll see these strains that are coming in, and you'll see people saying, what do we do? Is the vaccine going to be effective against them? And the current thinking is that yes. And the other thing to know is that this virus, RNA viruses, mutate quite a lot. So when they look at somebody who's ill and they start doing a lot of tracing, and you get the molecular geneticists in, and they look at every strain of the virus that the people are coughing out, you'll find that they are producing sometimes more than one strain, or there's more than one strain. So we think that there's probably more than one strain around all the time. It's when the strain that's predominantly infecting people changes. And so far, the current thinking is that both of these vaccines should provide protection against them. And we're just going to keep learning as we go.
And the nice thing about these vaccines too is they can be mass produced, and they can change. As that strain starts to change, they can add something to the vaccine pretty easily to make a difference. It's a messenger. So they're also using these vaccines to, when they talk about vaccines for cancer, that's the type of vaccine that they're talking about. So it's pretty exciting, I think. Yeah.
I agree. I think that's really cool. You've said both of the two vaccines that have already been approved are pretty similar. Would one be better than another for someone who's a survivor, or are they pretty equal in terms of effectiveness?
Yeah, they're pretty equal. And the Pfizer vaccine needs to be kept at very, very cold temperatures. So there probably are some places where the Moderna vaccine might be the only one that's available to you. And I would say if you have a chance to get the vaccine, I would take it. We don't expect there to be any difference as far as safety between the two, or efficacy. If you're going through treatment, again, you might be just diminished response because of the treatment, but not so much because of the type of vaccine.
I would say that what I've learned is that because of the cold temperatures, the Pfizer vaccine requires dry ice. And so the hospital systems that have the freezers and the capacity tend to be the ones that have the Pfizer, and the smaller clinics tend to be the ones. So when I start looking at who's getting what and where it is, it makes a lot of sense, because a lot of it is just about how you can store them, because the most important thing is you store them correctly so that they work.
Exactly. That makes sense. I know that this is going to change, state by state, county by county, but how does someone know when they would qualify for the vaccine?
It is, so you'll see that this is confusing, because that would be the theme for COVID-19. There are recommendations, and they come from the CDC and actually they come from the vaccination cohort. And they have a 1A group, which includes frontline workers and healthcare frontline workers and people in long-term care facilities. They have a 1B group, which is a 75 and older, and then a different line of frontline workers, police, teachers, food, agriculture. They have a 1C, which is, again, a different type of essential worker, and they're very clear to go through it all in the CDC. And it's that point where they have not just 65 and over, but in 1C, they have 16 to 64 with high-risk medical conditions. And those are including obesity, diabetes, COPD. And interestingly, they note immunocompromised state from a solid organ transplant and a sickle cell. And then they go on to delineate phase 2 is everybody else. And so this is where you speaking specifically to your oncologist as to in your state, in your region, where you fall. And it's not always just based on, we're talking right now about cancer and surviving cancer and therapies, but you could be somebody who's in recovery, but you are 75 years old, or you are somebody who is in recovery who's 45, but you have type 2 diabetes and you have chronic lung disease as a result of something or some form of treatment. So every individual is going to have a different place that they go. So all of the states and counties and regions are rolling things out based on supply. I think that's one of the most frustrating things. In our state, the state controls all of the vaccine doses. And so they are parsing it out. In other states, they've gone directly from the federal government to the counties. So every area really does have a different narrative. And that is why when survivors or supporters are talking to their friends in other states and they feel like, am I crazy? How is this person have access and I don't? That's a big part of the narrative.
Yes,
frustrating.
Sure, and I know that. Steph, this is a question for you. If someone is in active treatment right now, and would there be a certain time within the treatment cycle that the vaccine should be given?
So probably when your immune system is at its peak, or the best it's going to be when you're going through treatment. So
just prior to the treatment.
Probably just prior to treatment. But again, ask your doctor, and you can talk about timing. Because if you're due for any other vaccines during that time, you shouldn't be getting the COVID vaccine within a certain period too. So it's all about timing.
And as survivors, we know that you're constantly getting your blood checked when you're in treatment, and even as follow-up. And so if those numbers are low, that may change whether or not it would be an appropriate time, I'm assuming, for someone to get the vaccine.
Right. So depending on which vaccine, it's either 3 to 4 weeks between the first dose and the second dose. So it needs to be a minimum of that time, but it can be pushed back a little bit if needed. Yeah. So if at week 4 with the Pfizer, you're not quite ready for it, they could probably give it to you at week 5 or week 6.
Okay, you can go that long. That's good to know.
Well, and I also think to add, I think we're going to find as we are rolling out with this vaccine. So what we're going with right now are the recommendations from the study, because that's how we know we're going to get that 95 or 94%, against the virus. However, we're going to have people that started out getting their first vaccine and something happened. And then we're going to get data. So as we roll out the vaccine, you're going to find that recommendations are going to change, because you would never make that recommendation to not follow the guidelines. But, as my kids, when they were little, would say, like, sometimes uh-oh happens, something happens. And all of a sudden, we're going to have a lot of people that didn't completely follow the regimen. And then there's going to be data and information from that. So if in 3 months things change, you don't have to say, oh my gosh, they changed the rules again. This is driving me crazy. They're going to have vaccinated so many more people. And so there's going to be more data. It's hard to adjust to that, but that also changes how we answer.
It's a lot of data all at once.
Mm-hmm. Yes, I'm sure that some statistician is really just spending a lot of time in all of that number land.
Oh, I can't imagine.
After you get the second dose, are you considered to be at full efficacy? I'll throw it to you, Libby.
Yeah, well, so for the data is saying, the studies are saying with the Moderna, you get your first dose and you get your second dose 4 weeks later. And then a week after that, you are considered to be at full efficacy. So that's 5 weeks from that first dose. With Pfizer, it's 3 weeks, you get the first dose, 3 weeks later, you get your second dose, and 2 weeks after that, you're considered to be full efficacy, which is, again, 5 weeks. So from that first dose, if you've gotten your second, you should be protected at 5 weeks.
Okay, let's say you've gotten your second shot, it's been 5 weeks. Do I still need to wear a mask?
Yes. I mean, so the fair answer is we don't know. And so when we don't know, and the risk is a lot of people getting ill, we tend to err on the side of let's be safe. And if we find out we didn't need to worry about that, then we can change it. I think that the reason is this. What we do know is that we've never had an epidemic, a treatment, and a molecular test all at the same time. So I got chickenpox when I was a kid. There wasn't a high incidence of chickenpox in the herd. Everyone in my family got it. I then never got it again. I'm sure I was exposed to it again, but we never were testing me because I was exposed to someone to see if I possibly was carrying it and I could have given it to someone else in school. I wasn't ill myself, but we've never had a time where we could gather all of this data. We know right now that though I am vaccinated and am protected, no one else in my family is, and most of my peers are not. So and there's a high incidence of disease. So if I'm exposed to somebody and my immune system, the virus, for me not to react to it, it's not like I'm permeable and it bounces off my skin. So someone coughs on me, it gets into my system. My immune system says, oh, that, and I don't get sick. I might not have a symptom at all, but we don't know. Does that mean that if I swab, I could be positive? And the positive swab is possibly real. Could I then infect someone? And we've never had this at the same time. So we really don't know. So until our numbers go down and we have more of the population vaccinated, we're asking people to continue to mask, but you can mask with a little bit of a deeper breath. right? You can feel a little more calm that things are a bit safer. It's not the happiest answer because everyone is ready to go back to normal, but it is the real one.
Of course. Could you get COVID after a vaccination? Like a month or two later, let's say, not from the vaccine, but be exposed
we
to
know
it.
we know that with vaccines, and Dr. Archer can speak to the fact that even with pediatric illnesses, that they don't always, not every single person gets immunity from every vaccine that we give. There's always a small subset of the population that might not, the word is take, which isn't, it's not the scientific word, but they may not end up getting the protection. When the diseases are low and everyone's vaccinated, we don't have to really worry about them. So with this, you may see that.
With non-responders, right?
Right, non-responders.
And when we say 95% effective, that's pretty much what we mean, that 95% of the people did not get severe illness. But there's going to be those people that do. There's going to be people that, maybe it's not as bad as it would have been without the vaccine, because you have your immune system kicks in, but not completely. Mm-hmm. So
we anecdotally notice that with the flu season a lot. You'll interview when we have lots of flu in the hospital. I'm always asking, did you get a shot this year? Because I'm always interested. I know what strain the patient has. I know what strains were in the vaccine. And I will find a lot of times that I will anecdotally notice that sometimes you have patients that had the vaccine and got ill. Most of the time, they're not our sickest patients. But that's my anecdotal stuff.
Sense. I want to make sure we have some room for questions. So I have one final question, and that's for you, Dr. Archer. Would you mind sharing what made you decide to go ahead and get the COVID vaccine as a survivor and as a physician? And can you share your experience so that others know what to expect in terms of side effects?
So as a survivor and as a patient, it's actually pretty selfish, but I didn't want severe COVID. I didn't want to be one of the people that was in the hospital, and I didn't want to be one of the people that 6 months later was still having symptoms. As a physician, I know that vaccines work. Libby mentioned chickenpox. When I first started practicing, we had chickenpox, and now we don't. I mentor residents who have never seen a case of chickenpox because now we have the chickenpox vaccine. So I know that it works. I know that that is what it was going to be needed. Lots of people getting vaccinated is what we're going to need to get this under control, to get our lives back to whatever semblance of normal we can. And I also wanted to be a role model for my patients. I wanted to be able to say, look, I got it. And I recognize that there is a lot we don't know. There's a lot we don't know about COVID, and there's a lot we don't know about these vaccines, how long they're going to last, how good they're going to be against new strains. But again, I do know how dangerous COVID can be, and I know that I was surrounded by it. And because of my own medical problems, I could be at increased risk of complication. So that's why I got it. That being said, my own experience, I was actually scared to get this vaccine. I've had reactions to the flu shot. I haven't needed an EpiPen, but I've had to take Benadryl after the flu shot. So I was a little bit nervous. At first I was going to wait and see what happened to everybody else and wait till we get more numbers. But then our own numbers in Pittsburgh just started rocketing. And a family member was prolonged illness from it. So I decided that it was better for me to get it. So I got it. The first vaccine I did fine. I just had my second one last week, so I'm almost safe as far as immunity. The second one, my arm hurt. I was really sore the next day, and I did get a fever. And I want to point out that that's actually not an allergic reaction. That's what happens when you get vaccines. It stimulates your immune system. You get a fever. You'll feel a little achy. People always say, oh, I got the flu shot and it made me sick. Well, it made you feel a little sick, but it goes away. So I had a couple of hours from Saturday afternoon into Saturday night where I just underneath the blanket and drank lots of fluids and just took a nap for most of the day. and then I felt fine. And the other thing is that I signed up, when I got the vaccine, I signed up for the CDC's monitoring system, and UPMC has one. So I would get an email every day. It's time for you to check in. So I checked in, and when I told them that I had a fever and that I felt bad the next day, I got a phone call for a follow-up. So I'm glad to know that they're continuing to track this. They're continuing to watch. I do think they're being pretty transparent. And again, I think we have to recognize that people have a lot of concerns about these vaccines, and that's completely understandable. And why, again, we just want you to talk to your own doctor about it, about the timing, about your chance of reaction, about what your side effects might be. So thanks.
Thank you for sharing that. I think that was great information, and just hearing from a real person who has done it. I do have some questions. You may have already answered this, but this comes to us from Katie. What are your thoughts on asymptomatic positive COVID tests being tested for antibodies? And is there a time that they should be tested? And will that change the timing if they may have been initially, or if they have been initially infected?
Okay, so that's a lot of information, in that question. So I think the first question was, what do we think about people with a positive that didn't have symptoms being checked for antibodies?
Yes. Yes.
I don't know. There's a thing in medicine where we should do a test if we're prepared to handle the results. And if we don't know what that's going to tell us, I don't know if we should do it. I had a patient today, she is fairly convinced that last March she had COVID, and she got through it, and she wants to be tested for antibodies. Well, it's a year later, almost a year, and we don't know if those antibodies are still going to be there. And if they are there, how good are they? I believe that the testing is just testing, are they present, not do they work and in what amount? And so, again, don't know what we're going to do with it. And right now, we still have to mask. It doesn't really change anything. We still want people to mask. We still want people to be careful, stay home when they're sick. So I don't know if that's a good idea. Now, if you are sick with COVID, that piece of virus that they test for can stay positive for a long period of time. So in general, if you're sick with COVID, you should get the test. You find out you're positive. No need to test again. It's done. It's over with. If you're feeling better, if you're someone with mild disease, or you didn't need to be in the hospital after 10 days, you are most likely not contagious. No need to have that negative test before you go back to work. Now, if someone was in the hospital and they needed to get oxygen or got plasma or remdesivir, then they are probably contagious for a little bit longer, maybe 20 days after that. But again, if 20 days afterwards, they're probably not contagious, no need to test again.
The repeat testing is often done just because some of the nursing homes, if people out there say, I heard they tested my mom before she went to a nursing home, why did they do that? It's because we have to acknowledge that the highest risk that an asymptomatic patient could be is in a skilled nursing facility, highest mortality of those patients. So that is something that is still being practiced in the hospitals because we don't have a better way to do it. But nobody else, there's no data that says that, that there's any reason to repeat test anyone.
Okay. I have another question here for you. It comes to us from Marion. If I was shopping at a crowded store, is it beneficial to change my clothes in case they were exposed, or is that overkill?
I would say personally that I don't do that. If the way I look to a crowded store is that if it's so crowded, I might give more space between myself and the other herd members in the store. Not as much changing my clothes, because unless I'm sort of inhaling my clothes within very minutes of someone coughing on me, that isn't the thing I worry about. But I would absolutely encourage you, especially if the incidence of disease is high in your area, and if you're in treatment, but at anyone with risk factors, you want to put space between yourself and other members of our herd. And so finding times and ways to be apart is much more important than changing your clothes.
But wash your hands.
But definitely wash your hands.
There are a few, I think we've really handled all the questions. Some of the other questions are more at a personal level. And I think the response would be speak with your own physician. I'm going to throw those out to you. I think we have gotten through them all. If I missed someone's question, I apologize. Feel free to put that again at the bottom. We can reach out to both of these lovely ladies and get your question answered. I want to make sure that everybody feels confident in what was shared today, and that you can then use this information, as we've said again, to go back and talk to your own physicians. That is a lot of information that was shared today, and I personally, it was helpful to me. I'm sure that those who are viewing it live and those who will view this afterwards are going to feel the same way. So thank you, Libby. Thank you, Stephanie, for sharing your expertise and your experience with us today.
Thank you for having us.
Yeah, thank you for doing this. It's nice to have good sources and good places to go when there's so much out there. So thanks for creating a place for people.
Well, thank you both very much. And to everyone there out there, have a great rest of your day and stay safe. Mask up.